Okay, picture this. You're working a busy shift in the ER, and the triage nurse rolls in a new patient. You take one look, and it's absolutely unmistakable. The patient's skin, the whites of their eyes, distinctly yellow. Your patient has jaundice. So what's your first move? Time is of the essence, and you really need a structured plan.
Well, welcome to this explainer. Today, we're diving into a step-by-step clinical algorithm based on the absolute latest evidence. Let's crack open this Jaundice Playbook together and see exactly how we can transform a moment of clinical panic into a clear, actionable workflow.
It's kind of like a giant puzzle, right? Every jaundice patient that walks through those doors represents a complex clinical mystery. But by mapping out the entire investigation, from the second they hit the door all the way to definitive treatment, we can solve it systematically. We're going to break this whole process down piece by piece. So here's our game plan. We'll start with the initial evaluation, figure out the hyperbilirubinemia type, walk down both the unconjugated and conjugated pathways, flag the critical red flags, and wrap up with etiologies and management. Let's jump right in. Step 1, the initial clinical evaluation. Your patient is in the bed, and you need data like yesterday. We need to pull a CBC, liver enzymes, ALT, AST, ALP, GGT, and check tests for synthetic function. But here's the absolute game changer, fractionated bilirubin. You absolutely must know how much of that bilirubin is conjugated versus unconjugated. That one result literally unlocks the rest of your clinical workflow. Moving to step 2, finding the hyperbilirubinemia type. Based on that fractionated bilirubin, we hit a massive fork in the road. On one side, we've got unconjugated predominant. That's our indirect hyperbilirubinemia. On the flip side, conjugated predominant, or direct hyperbilirubinemia. Figuring out which side of the fence your patient is on dictates absolutely everything you do next. It is crucial. Let's explore step 3, the unconjugated paths. If those labs point to indirect hyperbilirubinemia, we're rounding up 3 main suspects: increased production, impaired conjugation, or maybe a drug-induced liver injury. To figure this out, we need a few extra puzzle pieces. Think reticulocyte count, haptoglobin, LDH, and a peripheral smear. Oh, and definitely do a deep dive into their medication history. We're hunting for systemic issues here, or maybe it's just something benign, like Gilbert syndrome. Now here is a massive takeaway. If your patient is predominantly unconjugated, do not send them for scans. Imaging is usually not indicated. Just skip it. Instead, channel all that energy into finding and treating the underlying cause. That might mean managing a hemolytic disorder, treating sepsis, pulling them off a toxic drug, or just reassuring someone with Gilbert syndrome. Let's rewind and take the other route. Step 4, the conjugated path. So, if the labs pointed conjugated, we're suspecting hepatocellular injury or a biliary obstruction. And unlike that unconjugated path, this scenario absolutely demands immediate visualization. Your first line of defense? An abdominal ultrasound. We need to quickly check for biliary duct dilation, look for gallstones, or spot any early signs of cirrhosis. When radiology calls back with that ultrasound report, there is really only one pivotal question you care about in that exact moment. Is there ductal dilation? The answer to that single question instantly splits our workflow again into obstructive versus non-obstructive causes. If there's no dilation, an obstruction is pretty unlikely, so we start thinking about non-obstructive hepatocellular issues, like viral or alcoholic hepatitis. But if you do find dilation, boom, you're likely dealing with an obstruction. If the ultrasound actually spots a gallstone, awesome, go ahead and proceed to management. But if a stone or mass is causing dilation and the cause is still unclear, you've got to escalate. Step up to a CT of the abdomen with IV contrast or an MRCP to get a really detailed map of the area. Which brings us to step 5, critical clinical red flags. Now, while you're methodically working your way through this algorithm, you've got to keep your radar pinging for immediate life-threatening symptoms. We're talking Charcot's triad, fever, right upper quadrant pain, and jaundice. That combo screams acute cholangitis. Also be on extremely high alert for an elevated INR, which points to hepatic synthetic dysfunction, altered mental status, or severe conjugated hyperbilirubinemia. If your patient hits on any of those red flags, you drop everything. To quote the source material directly here, these patients need same-day imaging and subspecialty consultation. You're getting gastroenterology, hepatology, or general surgery involved immediately. At this point, it's no longer a slow-paced investigation. It is a full-on, urgent rescue mission. Finally, step 6, etiologies and final management. So, statistically speaking, what's actually making our patients sick? In the US, the data is pretty revealing. Sepsis actually leads the pack, causing about 22% of these cases. Decompensated chronic liver disease is right on its heels at 20.5%, and alcoholic hepatitis accounts for 16%. Just those three alone make up a huge chunk of the cases you'll see. Keeping these probabilities in the back of your mind really helps anchor your expectations. Once you've finally nailed down that definitive diagnosis, it's all about execution. For choledocholithiasis, gallstones in the common bile duct, your go-to is an ERCP, maybe with a stone extraction. For a malignant obstruction, you're looking at biliary stenting or getting surgery involved. If it turns out to be a drug-induced liver injury, the absolute best move is simply pulling the plug on that offending medication. Supportive care is always a foundation, but targeting the specific cause is how you actually resolve the problem. Before we wrap up, there are a few golden rules of imaging from the source material you absolutely need to commit to memory. First, ultrasound is your undisputed first-line test. Crucially, a normal common bile duct caliber on an ultrasound has a 95 to 96% predictive value for ruling out choledocholithiasis. That is incredibly powerful clinical data. If you need to define a malignancy, CT is superior. For detailed biliary mapping, go with an MRCP. And please, just avoid plain radiographs. For jaundice, they're practically useless. And there you have it, the complete Jaundice Playbook. We've worked through the initial labs, navigated those tricky unconjugated and conjugated pathways, and highlighted those absolute do-not-miss red flags. So the next time that yellow patient rolls into triage, there's no need for panic, just pure structured clinical logic. So I'll leave you with this. With this algorithm fully internalized, what's the first move you're going to make to save your next jaundiced patient? Thanks for hanging out with me for this explainer. Keep learning, keep trusting your clinical pathways, and I'll see you next time.